Hello, everyone, and welcome to today's webinar, Mastering the Art of Care, Strategies to Improve Care Delivery and Address Physician Challenges. I'm Angie Stewart with Modern Healthcare Custom Media. I'd like to thank AMN Healthcare for their sponsorship of this event. AMN Healthcare is a leader and innovator in total talent solutions for healthcare organizations across the United States. The goal of today's session is to provide you with strategies for elevating the quality of healthcare delivery while addressing physician challenges and organizational complexity. Let's review some technical details before we begin. Those of you in our audience will be in listen and view only mode, but we encourage you to participate. Near the end of the hour, we'll wrap up with a question and answer session where you'll have the opportunity to submit questions for our panelists. To participate, please enter your questions in the chat function at the bottom of your screen. With that, I'm excited to hand the floor over to our moderator, Carmen Kenrick, Division Vice President of Strategic Accounts at AMN Healthcare. Carmen, the floor is yours.
Great, thank you, Angie. And thank you, Modern Healthcare. We are excited, and what an honor to sit here in Massachusetts, 7 miles from Boston, with this panelists that you're about to get to know here. And this session is really, it's for you. So we can't wait to hear your questions, and we'll be looking for your questions. So please don't be shy, as we have what we think are some great discussion points. So let me now have the panelists introduce themselves. And Dr. Agarwal, if you don't mind starting off.
Absolutely. Good afternoon, everyone. I'm thrilled to be here. My name is Abha Agrawal. I'm an internist by training with also board certification in clinical informatics. I'm presently serving as the president and CEO at Lawrence General Hospital in northern Massachusetts. Before that, I spent about 13 years as a chief medical officer. So I'm grateful to be part of the discussion.
Thank you, Dr. Agarwal. Dr. Mitty, if you can go next.
Sure. Good morning and good afternoon, depending where you are in the country. My name is Roger Mitty. I'm a gastroenterologist by training. I currently serve as the president and chief operating officer of Care New England Medical Group, which is a 700 provider medical group in the great state of Rhode Island. And nice to be with everyone today.
Great. Thank you. And Dr. Thaler?
Hi, good morning, everybody. I'm Klaus Thaler. I'm the Chief Medical Officer for Creighton University Medical Center, and by training, I'm a surgeon.
Great, thank you. And last but not least, here we are, Dr. Walter Tremblay.
Good afternoon, everybody. I'm Chip Tremblay. I'm an OBGYN by training. I'm currently the CMO of the Regional Medical Group for Trinity Health of New England. And I'm located in Connecticut. So thanks for having me today.
Great, thank you. So let's get into this discussion. So team, and I'm sure the audience, you're constantly seeing, whether you're reading it in Becker's, you're reading it on American Hospital Association, you're getting over, I'm sure, tons of information about how healthcare systems are continuing to consolidate. We are merging, we're getting bigger. And with that, we wanted to talk a little bit about how are we seeing the physicians, the physician role, the physician in leadership, how is that impacting you? And we're going to go around with the panelists to talk about that. But you just heard in the introduction, all of the four have been in the C-suite, they're CMOs, COOs, CEOs as well. So let's just start off a little bit about Dr. Agarwal. As far as you now as a CEO, your journey from a CMO to a CEO, and I'm going to bring everyone to talk about as the systems get larger, how is that? What is your reflection as to the role of the physician leader?
Thank you. I am happy to start. So as you know, I became a CEO by way of being a CMO. And that background has given me a very strong understanding of the indispensable role physicians play in the healthcare leadership. Our organization hadn't had a physician CEO, at least in the last several decades. So as I joined, my focus on ensuring physician engagement itself was found by physicians and most other people to be very refreshing and valuable. Um, I was also a very docs CMO, so I can definitely say our CMO has been happy, I think, to have me. I think if I put it simply, there are three attributes that I have found very important to be uniquely in physician leadership. Number one, to be a team player. I think a CMO succeeds by recognizing that physicians are part of a care team and that we succeed in delivering the outcome for the patient when we play along with the rest of the team. I mean, our training as physicians fosters in us a sense of autonomy and independence in decision making. So we have to achieve that balance and constantly be aware of that. I've seen quite a few physician leaders falter in that, and I think that's core to our success. These are contradictions, but we got to manage that. The second piece is going to be the effective advocacy and liaison with the administration, especially in a large, complex organization. The CMO becomes an effective advocate for physician interest, and I'll talk a little bit more on that in the larger organization. But the third point is it's not about physician interest. I think I found it to be extremely important to stay true to the singular most important goal, almost, self evident, but that is the patient care and the patient outcome. You know, many executives on the team are non physicians, non clinicians. And I found that the biggest value I would contribute as CMO was that kind of deep, visceral understanding of the clinical environment. So I think it's extremely important, whether it is a CMO or a CEO, to never forget the true north. And many non clinicians do not bring it viscerally to the role. And I would say, last, look, there is research that physician led organizations have found to perform better. There's Harvard Business Review articles, there are New York Times articles. So I couldn't be more excited that physicians should take a tremendously influential, foundationally shaping role in a healthcare organization. And we are
Thank
good.
you. Thank you, Dr. Agrawal. You just reviewed a number of fabulous points, and I want to tie in your three colleagues, your three panelists here as well. So right now you're in an inpatient setting, as you mentioned, and so you just covered quite a bit of things from autonomy, team player, the advocacy. Now, Dr. Mitty, you're in also as a C-suite in a CEO role, but on the ambulatory side as well. Anything you want to add to that as far as the development, the growth of a physician leader?
No, I will echo many of Dr. Agrawal's points, which were beautifully put. I will say that, many of us are seeing the concentration of a health system starting to move from the hospital-centric world to more of an ambulatory first strategy. And, with that, the traditional role of the CMO, who'd been sort of a hospital-based, and to Dr. Agrawal's point, the sort of go between the medical staff and hospital administration, that's changing as the focus moves away from hospitals. So we're seeing our CMOs become more and more involved with our ambulatory strategy and our physician strategy outside of the four walls of the hospital. And it's a very exciting time, I think, to be a CMO. And I would say that, the more experience someone who's interested in becoming a CMO or any sort of physician leader, the more experience they can get in the different realms of the healthcare system. So obviously inpatient, outpatient, network development and payer strategy, being able to concatenate all of those will make someone even more effective in the role. It's a really exciting time and a time of change in healthcare.
Great. Thank you for that. So Dr. Thaler, you're now in that academic setting. And so you've had this project, you've gone from one setting in a role and you've blossomed as a physician leader. Tell us a little bit about, as you reflect, what you're hearing from Dr. Agrawal and Dr. Mitty. Anything you want to add also from the academic setting and the physician growth in that setting? Okay, when we were having a little technical Can't hear you, but
Sorry, I was unmuted. I have to unmute myself. So I think on the academic side, I agree with everything what Dr. Agarwal and Midi said about characteristics of physician leaders and requirements. I think in addition to that, an academic physician leader need to have, the background of an academic environment, how the academic world functions in comparison to the community. I think everything else is really pertinent with presentation. I also like to add that physician leaders have strategy, be it academically or non-academic, regarding growth of healthcare systems, regarding the directions where healthcare systems go, because they are, and it was mentioned previously already, they are the connectors between the clinical and the non-clinical world. I think everything else was already said.
Thank you, Dr. Thaler. We are having a little bit of hearing you, but from what I hear that you mentioned, I love how you summarized it, that the physicians are the connectors to the clinical world. So thank you for what you just highlighted. And Dr. T, as a CMO and COO for Trinity Health in New England, now let's tie it back to, again, you're wearing two hats. So we are finding that as we're condensing and health system organizations are growing in size, that leaders are doing more with less. Here you are as a CMO, COO. Anything else that you wanted to talk or add to this discussion as a physician leader?
Yeah, it's always great to have a last name that starts with T. You get to agree with everybody that talked before you. So I would really highlight a couple of points that have been made, and those are that this is a team sport. At Trinity Health in New England, we have 5 hospitals, and then we have a very large outpatient footprint, ambulatory footprint. And what we've done at the CMO level is we've divided our tasks. I'm one of 4 CMOs. So there is a hospital CMO in each of our markets, and they have a more traditional role, as Dr. Midi described, where they're on the floor in the hospital every day, managing ODE, managing the physicians, quarreling with each other in the operating room. And then I've been tasked with the CMO roles and the operational roles that specifically affect our ambulatory activity. All of our providers are based out of the medical group, and so I sometimes have to team up with my hospital CMO counterparts in order to have everything come off and be effective. But I think that as we move forward and the systems get larger and larger, there's just no way for that traditional hospital-based CMO to do all of the tasks that are out there. So each system, I think, is growing a little bit differently in how they're conquering that. But we've conquered it by division to some degree and separating the two aspects, which is nice for me because I'm not so worried about some of the day-to-day in the hospital and can focus on the operations of the ambulatory setting, which I think are dramatically different. And so for those that are watching today, figure out where your passion is. Nothing gets me excited like a great, ambulatory schedule, a footprint, getting my docs around the community to care for the patients that are out there. I think if I had to take care of ODE all day, that would lead me to leave this role. But I think figure out what you like and then grow into those areas, because more than ever before, I think they're out there to be had.
I like how you summarize it, Dr. T. Bringing in our audience, love it. Thank you for that. So now, as we're looking at physicians as leaders, those connectors, and I think you use also the word of conquering different strategies. Let's talk a little bit about value-based care and what we're seeing throughout healthcare systems as we're looking at what the community is asking for, the payers are asking for, and how is this value-based model impacting you in your roles as leaders? And I wanted to highlight a little bit here, Dr. Mitty, as to your journey and what we've learned in our conversations about what Care New England has been looking at, investigating, discovery, implementation. So can you tell us a little bit about your journey on the newest hot topic, which is the value-based model?
Sure. And I think, everyone, on this webinar is facing this in one way or another, which is we are making this gradual transition from, the fee-for-service world into the value-based world in terms of how we're being compensated, both at the physician level as well as directly by the payers to the health system. And it is by no means easy work. And one of the things that's tough about it is that it's gradual. So, we're dipping our toes in now. My guess is all of us 10 years from now will be a lot further along in value-based, but it is tricky to try and, phase things in, especially when you're talking about physician compensation, because obviously that's something that the docs hold near and dear, as well they should. So our journey at Care New England, we've got about 7 or 8 risk contracts now. And our decision basically was about 1.5 years ago to move our physician compensation so that 20% of the doc's overall income is related to their performance in value-based metrics. And, previously the physician's bonuses had been based on volume, and as most of us are doing right now, which is the more RVUs you get, the more you get paid. So we took about 20% of that and attached it to metrics, loosely, or in some cases more firmly tied to what the payers were doing. So things that we're all familiar with, such as HEDIS measures and accomplishing and meeting HEDIS measures. And then, growth, which basically was individual physician panel size. And again, that, I think when you look at panel size, it lets us make a nod to the doc. And we understand that a physician with a panel of 1,500 patients has a lot more out of the office or out of RVU generating work. So we will compensate them for that based on panel size. Obviously, quality, we chose annual wellness visit completion as a quality metric. And again, that's something the payers are very interested in, as everyone knows. Another one was HCC scoring and RAF scores, and obviously being facile and starting to pay attention to HCC coding was something that we've asked our docs to do, and we're compensating for that. And then finally, access. Again, Blue Cross of Rhode Island is very hot on access, and so we've created a metric around that, which is to say that you need to have same day or next day access in your practice, and that's really difficult because docs are really busy. So we haven't made that on an individual doc basis. We've made it on a practice basis. So even if you can't see the patient, either an advanced practitioner in your office or even a telehealth advanced practitioner that we have serving our entire group would qualify that to meet that quality metric. So that's how we've dipped it in for year 1. Year 2, we're probably going to start to add care coordination as a metric towards their quality dollar. But this is definitely work that's in progress. And I will say the one clue I'll give everyone before I stop is we made year 1 a hold harmless year. So because we knew it was brand new for everybody. So we basically said no one will take a pay cut in the first year of this based on their performance. It's a test year. And then following years, we'll actually hold folks responsible.
Great. Thank you for that, Dr. Mitty. So the highlights when you're saying, when you're looking to implement this value-based model is the gradual approach. Love, as you summarize that, you're looking at your medical staff and you're saying, okay, let's make sure we look at you as whole for this year. So it will tie into our next question regarding recruitment. But let me go to Dr. T as I'm hearing about the value-based and how everyone's in a different stage of looking at value-based model, because it obviously depends on the state, It depends on, because I know Dr. Thyler will have a perspective as well from the Midwest. But Dr. T, can you reflect a little bit about Trinity Health in New England and the value-based? Because I know from the perspective of how you look at physician compensation, we talked a little bit about the typical model of fee-for-service or RVUs. But can you talk a little bit about your journey looking at this value-based model?
Yeah, and our journey is across a state line. So we have one of our markets is in Springfield, and Massachusetts, as everybody knows, is well ahead in the value proposition, I think, or at least that's my observation. And then the remainder of our team is in Connecticut. We've and to that end, I think our team in Massachusetts is somewhat ahead in contracting, et cetera, in comparison to our Connecticut team. That said, our medical group is somewhat young. Trinity Health of New England is a relatively younger system, and we're working toward the same things I think that they are, in, that Dr. Mitty's group is in Rhode Island. We're trying to figure out how to move quality and value into the compensation equation. We are still predominantly an RVU-based compensation model. One of the things that we've been really looking at also is trying to decide, at least up front, who it makes the most sense for. And at least this proceduralist OBGYN finds that a lot of the value propositions seem to, at least at face value, fit better with primary care than they do with our specialists. And so, and given the importance of primary care, I think what we've been working toward is trying to figure out the best way to fit the primary care pieces together in the value proposition, and provide those folks with some of the benefits of the value proposition before we have focused on the specialists. Specialists do so many operations or so many procedures, and that's their thing, and they're good at that. So we've been looking at that piece as well. I don't think we're unique in any way, shape, or form. I'm sure everybody on this call is facing the same challenges, but making it all fit together and taking best advantage of the opportunities, I think, is where we're all at, and that's what Trinity Health is doing.
Great, thank you for that, Dr. T. Dr. Thyler, I'm hoping that the audio is working for you, because I know you're on a different journey out Midwest, and we talked a little bit about this, but can you reflect a little bit on what you're seeing from the perspective of the compensation with your physicians, but how your journey for looking at this value-based model that everyone's been talking about?
Can everybody hear me?
We can right now, yes, thank you.
Yeah. So I think starting with quality, when you develop a bonus-based program, incentive-based program, is certainly the right way to go. I have to go with Dr. T, what he said about the specialists here. So on the PCP side and on the internal medicine side, I think it is in place, and it is very important. I would add the quality, also patient experience, which is a growing important part of value-based purchasing. On the specialist side, because they're doing so many procedures and they should be incentivized for the clinical part, I think we need a quality-based incentive program as well. And that's currently on its way. And I'm hearing that this is also not in full implementation at my partners or colleagues' systems as well, because that is more complicated. But I think it's definitely doable, and for programmatic specialty services like trauma, it's in place, and it's also a requirement if you're a level 1 trauma center, as an example. What makes it a little bit more complicated for academic services is academic systems, that you have the educational part there, and you need to commit to education, and you need to reserve part of that overall compensation also to education. So that comes certainly into play besides quality on the academic side.
Great points, Dr. Thaler. And I'm going to finish here with Dr. Agarwal. So here you are as a physician, as a leader, and as the president of a community hospital. So there's all these challenges, and here's yet another initiative, right? And so from your lens, of course, of always wanting to provide the highest quality care, but with this model, can you just summarize for us as that hospital leader and what you're seeing, being that I know you are sitting in Massachusetts, but what you're seeing as far as the complexity of rolling out such a model, the value-based model?
Yep, thank you so much. Agreed with most of what was said, especially with Dr. Trembolac, because his name begins with T. And, and agree with his observations that Massachusetts, having just moved from Chicago, is more progressive here, or more ahead of the curve, somewhat ahead of the curve. I think one thing that I want to share is, I think when you have a larger, more integrated system with multiple practices or practices and hospitals at a scale on one technology platform, it may be a little bit more straightforward to do value-based care. I think the premise of value-based care is clear. I do not even consider it as yet another project. Look, it's very simple. We should be incentivized, rewarded for providing value, not just volume to the patients, right? Pay per outcome, not just pay per click. The challenges that we encounter is if we do not have a scaled, large medical group, primary care physicians, specialists, hospitals. Instead, we are trying to create a value-based care model where we have 20, 30, 50 independent medical physician practices, specialty practices, community hospital, community health center, and then create a value-based model. The biggest barrier to us, if we can overcome all the business objectives and all of that and multiple entities and CEOs, is the technology. I mean, EHRs do not talk to each other unless you are on the same system and the platform. And, when we did meaningful use and, $36 billion of the national money invested and said there's going to be ROI, the premise was that EHRs will talk to each other. I've been following the EHR industry before it was an industry, I would say, at least for the last 20 years, very, very closely. The promise there has not been materialized, which is very much one of the barriers for organizations like us in value-based care, is the lack of interoperability in electronic health records. There are technical challenges, there are HIPAA challenges, there are administrative challenges. But so that's kind of, we can start to overcome those. And there have been efforts, health information exchanges, RIOs, this, that, but it's still the biggest barrier. So, and the second thing I would say, the barrier for us, is when in such a disparate environment, there is constant challenge of this arrangement is who is taking on the cost of creating that infrastructure, and then who gets the more value, hospital versus physicians, primary care versus a specialist. So I think the premise is great, but there are a lot of challenges in realizing the promise of value-based care from at least my viewpoint.
Fabulous. I love how we were able to capture and understand from all four of you your perspective. And I'm going to pull in now the audience. We have a poll question that you should be seeing, and we're asking for your feedback from what you're seeing in your organizations as far as quality metrics and what's working or not working, and if it is working in your organization. So we opening up that poll, and hopefully you'll be able to see that. And I will ask my colleagues here. I'm not sure how long the poll will take. Let's see here. Okay, so it's looking as that we hopefully by now you get to see the results here. So interesting, the majority of you are saying somewhat effective. So we have some work to do here on within healthcare And that's you know that's the challenge for us for leaders who are working in healthcare right now. So so thank you for that. Now let me switch over to the team, because I want to talk about our next area that will tie into what we hear consistently: the work balance, workforce staffing, and the well-being. We've been hearing quite a bit of the burnout topic, and I can say that from your perspectives, this can really open up the discussion as to how the team, what you're seeing. I mean, as a matter of fact, just last week, I saw even Newsday was talking about the shortage of physicians, the shortage of specialists, not just primary care. We're always hearing about primary care, but there's the wait time to see your doctor wherever you're sitting. And so as leaders, what are you, from the perspective of the audience, some things that you've worked on as a leader within your organization, and some results, some challenges, and your lessons learned? And so let me start off with Dr. T for Trinity Health of New England. If you can share from the perspective of, again, burnout, that work-life balance. I believe you had a great, some good perspective there. So if you don't mind opening up and talking to us about your lessons learned.
Yeah, no, I think a lot of us in my generation went into medicine because we felt that we were going to take care of patients, but also that we'd have some kind of control. The locus of control of our day, of our life would be in our hands more so than in somebody else's. And I think in 2024, in our large systems, gone are the days of the individual practitioner running their own office, right? And so we're faced with trying to fit the workforce into the plan, and making them all feel engaged and that they do have some control over their destiny. I think add that I've spent a lot of my career as a medical educator, and I think there are just significant generational differences. And as we get closer and closer to those graduating residents, who are, my kids, for example, you get to the point where you're looking at a group of folks who are very tuned into what work-life balance really should be. My forefathers were solo OBGYNs who delivered all their patients except for the 2 weeks they went on vacation. And today that's very different. I think even our patients are expecting to get a well-rested doc from a large group who's going to be present to safely deliver their child. So it's a very different mentality all the way around. We were faced with one of our markets where we were seeing a lot of burnout and a lot of folks complaining about their workday and not being able to get everything done in their workday and not being able to get to their families in a timely way. And we sat down with them and kind of hashed out in a group setting where the challenges were. And ultimately for that group, what we did was we moved to a very open physician schedule opportunity. So we said to our providers, we'd like you to do 2 4-hour patient sessions a day. Okay. You pick when they start and you pick how long you want for lunch, and you can pick therefore when the day ends. And we worked really hard with our support staff and our building team, our office managers. But we basically said, start anytime from 7 o'clock on in the morning, and we'll stay until the last person's 8-hour day is done. It took a little bit of scheduling and it took some work, but we managed actually with those, I think it's about 50 providers, to actually create an open opportunity for them where they set their workday. What we saw was that some of our folks with families may want to start very early and finish to be there to meet the bus at 2 or 3 o'clock in the afternoon. We saw other folks who maybe were younger and rolled out and wanted to start their day at a little bit later, but didn't mind going until 6:30 or 7 at night. The real win actually was that the doctors became more engaged. and reported, a higher love of their job. And the result for us in the leadership team was that now I had access for patients that went from 7 a.m. all the way till 7 p.m.
Right.
And for patients, that was awesome because they could start to fit their visits into their day by picking a provider that had availability when they wanted to come in. So it was a win-win, and we've worked at that across the region and are implementing that throughout Trinity Health in New England, and seeing some benefit with respect to our providers there. So it's one model. I guarantee others have skinned the cat a different way and come up with the same outcome, but that's what we've done.
Thank you for sharing. Dr. T, it's interesting, right? So you're looking at balancing your medical staff, balancing your ambulatory physicians to make sure there's that work-life balance. And then the outcome is positive for the community that you serve. So I as a lay person, being able to see my provider at 7 a.m. or after work, that I can then get to see my doctor in the evening. So great story. Dr. Mitty, you actually had shared also from the perspective of, tying it in. So you also said, Dr. T, that, and we've read this, we are working side by side with different generations, different work ethic, different way of talking about what does my job mean to me. So Dr. Mitty, as a CMO, as a president of a medical group, can you share also your perspective and your lessons learned and some of the challenges? Because we know this is a nice summary here, but this takes time to implement any kind of change to balance the work-life balance.
My favorite story is when I was a medical student in New York and my surgical resident said to me, he said, Roger, you know why I hate being on call every other night? Because I miss half the interesting cases. And, it's a very different world that we're in now. And, certainly in Rhode Island, where some of you are aware, physician compensation tends to be less than our neighboring states. We're very much challenged to develop a value proposition to bring physicians to practice here. And, I absolutely will echo what Chip says, which is, obviously we've got to create a work environment that is advantageous and lets our physicians sort of live the life they want to live while still getting our patients taken care of. So, we're very much focused on using technology to enable some of this. Virtual scribes is an area that we've sort of really dove into, and so far has been, we were piloting a couple of different platforms, and obviously the docs love it. It's reducing their pajama time. The other area that we get a lot of complaints about is inbox management and how much time it takes the physicians at the end of the day to go through the messages and the prescription refills and all the things that need to be done. And the truth is, probably about half the items in a physician's inbox don't need to be attended to by a physician. And so how can we leverage technology or other other opportunities to take care of some of the inbox work? And that's using either other physicians outside of the organization who we pay to do some of this work, or other members of the care team to do some of the work that previously had fallen onto the physician. And then the last thing I'll say is, along with what Chip was describing, we now have a team of triage nurses and advanced practice clinicians who will do telehealth visits with patients who call during the day, who can't get into the office because the physician is booked. And that way, the patient's taken care of by this other team. The physician doesn't have to make a phone call at the end of the day to talk to the patient. The patient's already been taken care of, and the patient feels like they got great access to healthcare, and the primary care doc can go home in more reasonable hours. So leveraging technology, leveraging other providers within the care team to do some of the work is how we're approaching it.
Great, thank you for that. And I'm going to tie that in because Dr. Agarwal, you had talked a little bit about technology, right? So we just talked about life-work balance. I do not want to go away also for recruitment. So I'll come back to that on physician recruitment and those challenges. But Dr. Agarwal, we started about 30, 40 minutes ago talking about the physician role and the growth of that role. But you also talked a little bit about, and how would this tie in, what as a physician, what you're learning in medical school, that autonomy. And tell us a little bit from your journey and as the C-suite, the president of your organization, when you are sitting at the table with your physicians and your physician leaders, and how you're approaching that burnout, that work-life balance.
Yeah. So two things I want to comment. I think autonomy is and a sense of control over their destiny, their work, that is far more at the heart of the burnout than anything else. And how technology has contributed to the sense of control. I love this case study about flexibility in scheduling. You choose the hours. I think might want to copy that model. I want to share with you a story. When I grew up in India, and I loved math and I loved being a doctor. And long story, but there was a dichotomy where you could either do math and pursue engineering, or you could do biotrack and become a doctor. And I decided to do math because I loved math so much. And my dad wanted me to be a doctor, right? The usual story. The way this I would never forget. He was very clever. He understood who I am. And the way he turned me was, if you are a doctor, you will have more autonomy. That was many, many decades ago in a small town in India. So that is the perception I grew up with. And doesn't matter where you grew up with, that's the whole idea of being a physician. And that has been taken away from us through EHR clicks, through RVUs, through no matter how well intentioned the value-based care. It's not that I am in charge of doing the right thing. It's that somebody else, including me, the CEO, right? I'm the enemy as well, telling me to do the right thing. There's a world of difference. So I don't have an answer, but I feel, how do we create the system where, as a physician, I feel I'm doing the right thing because I want to do it, not because Abha is telling me to do it. I don't have an answer, but at least it's my quest to figure this out. And
Right.
secondly, I want to second what Dr. Midi said about technology. Technology has created a lot of problems for us. All the EHR clicks, well documented. And now we are upon all the conversation about AI helping us with the inbox, with AI-based describing, with back office coding. And I'm like, I went to all the meetings and said how EHR will help you. And now I'm invited to talk about how I created the EHR created the problems and let AI help it. How do I face my colleagues with a straight face, right? Having said that, honestly, I can't help but be optimistic about the judicious use and application of AI. With what I've heard from Dr. Mitty and Dr. Tremblack, I'm extremely optimistic we can do it.
Great, thank you. Dr. Thaler, I'm going to come to you as far as, so we just heard that maybe on this panel, there isn't just one right answer, right? But we're on a quest, and I loved that way of describing it. Can you summarize for us what you have learned from that work-life balance, and then talk a little bit about recruitment and the challenges for, as a leader, recruiting physicians?
Okay, so in summary, I would say work-life balance, physician burnout, or provider burnout is multifaceted. It certainly got accentuated with COVID, but it certainly wasn't only COVID. It was there all the way, from financial health to physical and mental health. I think another important factor, what hasn't been mentioned yet, is to have adequate support in the workforce for physicians and providers, especially nurses. We had a significant exodus of nurses during COVID, and that certainly supported the burnout overall. And what I'm hearing from providers is physicians at mid levels that they are very, very anxious if they have to support when they go and treat patients on the clinical caregiver side, on the ancillary side, and how the future will look like for them. Switching gears to recruitment, I think we have a new generation that we recruit right now, and they have, and it was mentioned before, a totally different expectation. We need to accept that they have a different pace of work, a different work-life balance, and I think if you look at that, the quality, the life quality and the balance between work and life is most important for them, and it comes first. It's not that the pay grade or the compensation is ranked. They don't rank that as high as the other one. And I think the second one, before it even comes to pay, it needs to be in the right environment, which is not only the geographic environment, but also the business environment and the political environment.
Great. Thank you for that. So we want to open this up to hear from the audience, and you should see a poll being dropped soon. And the question is, what poses the greatest challenge to achieving a satisfactory work-life balance for physicians in your organization? So hopefully by now you should see something in your inbox or in your the panel discussion here. And we're curious to see what you're seeing, as you just heard from 4 different leaders from their lens. And as far as that walk away, we're seeing here now, let's see what we're seeing from you. So interesting. So interesting, the administrative burdens. So once again, going back to how can you as leaders go into a conference room, or when you're doing rounds, or when you're speaking to the work staff, how can you talk about, well, we just rolled out this fabulous EMR, it's going to solve your issues, but now let's talk about the next tool, which is AI. So you can see here, administrative burdens, 50% folks are saying that that's one of the things that, as far as the greatest challenge for physicians in your organization. So thank you for that. So that continues to be, once again, a challenge for a number of organizations. And then the second is that emotional stress and burnout, and how, as leaders, the systems, the opportunity to make sure that everyone has the tools, that you're listening to the providers, that you have mentorships, that you have stay interviews. There's many tools that leaders, I'm sure, are looking at to make sure that you retain your medical staff. And of course, really, it's not only the physicians, it's the whole team we want to retain, right? So I know we're coming up to time, and I want to cover this one next question, because as in anything, we just talked about that overall the role of the physician, the evolving role of the physician, tying that into then the value-based care, the reimbursement, work-life balance. And why don't we, in essence, as the 4, now we have about 3 or 4 minutes, and then we're going to open up to see what other questions we have. But let's probably expand a little bit more on, as far as that balance and seeing the reimbursement changes, as that is obviously affecting physician recruitment, affecting the bottom line of all of our organizations that we work in, those financial constraints, and how are you as leaders then making sure that you have the appropriate tools for the physicians so that they are able to get their job done, whether it's using data analytics, whether it's using the AI tools, et cetera. Can you share maybe 1 or 2 things that you're looking at right now, knowing that you have financial constraints? And so, Dr. Thaler, let me start with you. Quick highlights and some of those constraints and that you're seeing out Midwest.
So, and I don't think we're the only one here in the Midwest seeing this, but I think we need to work on our workforce, and we need to work on the financial constraints to start there. We still, everybody here and in other healthcare, most healthcare systems see still a lot of external workers, nurse travelers, tech travelers, and I think that these financial constraints we need to challenge, and we need to balance in the near future by not only increasing retention but also hiring permanent workforce, nurses, ancillary staff, and being competitive in the marketplace. I think the other one is making this also an efficient. So we gotta be operationally efficient as healthcare systems. And the healthcare systems traditionally, historically, haven't been the most efficient industries in the past. And we need to definitely improve that. And we need to do more process improvement. We need to teach our young providers, young physicians in process improvement, and our nurses. I think the educational work here needs to significantly grow in order to be more efficient, the hours we spend treating our patients, and that it will be also indirectly impact our financial constraints and add to the bottom line.
Great, Dr. Thaler. I'm sure all of us and the leaders also on the webinar can really relate to that process improvement. We're always looking at that opportunity to improve. Dr. T, as far as balancing, the two states that you mentioned and looking at those financial constraints and making sure that as leaders, you're looking at all the possible tools from technology, anything else that you want to add as from your lens that you're seeing some of those challenges as a leader?
Yeah, I think never before in medicine has the term "do more with less" had more meaning than it does today. I think the real tragedy of COVID is the reimbursement we find ourselves in right now. That resulting wave of decreasing reimbursement for the care that we provide. No, it's interesting because I don't have an answer to your question, Carmen, because so much of it is financially driven, and it is such a difficult time right now that we are doing what we can do with the things that we have. But a lot of times those new opportunities and initiatives, even something like, rolling out AI across a system like ours with, 100 hospitals becomes a very expensive endeavor. When you start to buy subscriptions, I have Trinity has, 100 hospitals across the US. I have 1,000, 1,200 providers in just New England. It all of a sudden becomes, big dollars to even talk about doing some little things. And those dollars just don't seem to be there right now. So it's a very interesting time. And I think I'll leave it at that because I think that's a whole nother webinar.
Absolutely.
Yeah.
Absolutely. Thank you. Let me come back, and maybe both Dr. Mitty and Dr. Agarwal, the audience is asking a great question I see here is, how do you balance provider autonomy versus standardization, right? So we're always looking at when the standardization of documentation, of process flow, the standardization of even, how do we see our patients depending on specialty. But Dr. Mitty, can you talk a little bit about the standardization versus autonomy, and then we'll go right to Dr. Agarwal.
Sure. So real quickly, obviously there's some things that are absolutely standardized. So quality, right? Everyone's got to adhere to the same quality expectations when they see a patient, and that we don't waver on. The autonomy piece, I think, comes back to what Dr. T talked about before, is we need to be flexible with scheduling. We need to be flexible with allowing physicians to use telehealth when they want to use telehealth. And we need to be flexible with physicians who want to dive more deeply into some of the technology-enabled parts of what we're doing. So, if you're going to use a virtual scribe, an AI-enabled scribe, well, then that may sort of, the quid pro quo maybe, well, then see a couple more patients a week to help pay for it. So that's sort of the interplay that we're looking at.
Sure, thank you. And then Dr. Agarwal, if we can finish up with you with that question from the audience.
So I agree with Dr. Midi. Let me just sharpen this a little bit more about standardization of care delivery. You know, partly we are to blame. If you remember, there was a landmark study in 2003 in New England Journal of Medicine that looked at a number of standard quality measures: cancer screening, diabetes-related screening, pneumonia vaccination. Flip of a coin, 50% of the patients received the recommended acceptable care, standard of care. So then with that, then you went to all the alerts and all of the clicks, etc., in electronic health record. So I just want us to also be a little bit introspective to say some of it is not just the administrative burden, which I talk a lot about, but some of it.
Oh, we might have lost Dr. Agarwal.
Oh,
there you are.
Here.
There you go. Some of it, you said.
Oh, sorry. So I'm saying some of it is the administrative burden, the way the system is structured much more toward payers and meeting coding and all of that. But some of it has been the variation in the quality of care that we were doing that was deemed necessary for us to have these clicks, etc. So I just want to have that nuance for us as physicians, so we don't always feel that we are the victims of some administrative heavy-handedness, right? We are in charge and we have the responsibility to provide that standardization. And then on the administrative side, how do we have the least friction in ensuring that quality of care? And the balance is hopefully somewhere there, right?
Yeah.
I think I want to maybe say one other thing that I recently learned on the finance side. You know, it's a simple mathematically, your margin is your reimbursement rate, your revenue versus divided by your expenses. Since the COVID, our expenses have gone up depending on what you do, 20%, 30%, 50%, 100%, right? Our reimbursement rate, especially as a safety net, have not gone up. Almost it's a miracle that all of us are still operating, especially us as safety net, where our reimbursement rate are so low. So All I would say is, look, if I can have the audacity of thinking I can make it work on a predominantly Medicaid, Medicare, I think there is hope for all of us.
Great. Thank you for that, Dr. Agarwal. We have a question from the audience. We have a couple of questions, and I'm sensitive to time, but this question is actually, I think it's a great question, as all of you have worked in health systems and currently, so the question from the audience is, what are some strategies that you've used to bring together physicians in the health system that have a health foundation supporting hospitalists, specialty practices, and primary care? Many of these practices are used to being independent. Dr. T, can you take a stab at that? And I know that time is not on our side, so you've got about 30 or 40 seconds.
Sure. I think the first thing that we've done at Trinity Health in New England is we've put all of our like physicians together in a service line. So we've teamed up those physicians that have things in common, whether it's cardiovascular services or surgery or OBGYN. First, we've given them their own identity through a service line. And then what we do is we routinely have our teams shuttle between other service lines with respect to grand rounds that are appropriate or other mixing activities. Certainly COVID put a stop to the traditional, bring everybody together somewhere for, a couple hors d'oeuvres and a seltzer at the end of the day. We're starting to get back into that as well. But I think first we've given them an identity with same across our whole region. And then we've started initiatives within the medical group where we mix them together for projects and activities, learning activities and social events, I think is how I answer that.
Great, thank you. I wish we had more time so that I can go around the Brady Bunch here, all the cubes here, and get everyone's perspective, but we're down to the wire here. And I appreciate your time for actually taking out of your very, very busy schedules. So we appreciate all four of you coming together. And I think in summary, it's always to share best practices. So hopefully the audience, you picked up one or two or three things or had a moment to say, aha. So thank you. And I'm going to now bring it over to Angie. And we're right at time.
Yes, unfortunately, we are at the end of our time together. Panelists, this has been an excellent conversation. Thank you, Carmen, for moderating, and thank you to everyone here for sharing your time and insights. I'd like to thank AMN Healthcare for sponsoring and helping to organize today's webinar. A recording of the video will be made available after the event concludes. Thank you to our audience for joining us today. Please don't forget to give us your feedback in the post-webinar survey, which will appear on your screen once the webinar concludes. Thanks again and enjoy the rest of your day. Take care.
Thank you.